We're now going to move into a series of rapid fire papers, the first of which is going to be delivered by Shin-Rong Lee, who is a third-year general surgery resident, and the talk is going to be introduced by Dr. Toca Garcia, or Dr. Garcia Toca. I am sorry, I'm sorry, Manuel.
So as Dr. Humphreys was alluding, Dr. Shin-Rong Lee, he's a third-year general surgery resident, and the title of his talk is Risk Factors and Management of Steele Syndrome After Hemodialysis Access Creation. Go ahead.
Hello, I'm Shin-Rong Lee. I'm a general surgery resident at Yale. I'll be presenting today on the risk factors and management of Steele syndrome after hemodialysis access surgery. We have no disclosures. Steele syndrome is a severe complication of vascular access surgery and manifests clinically as distal ischemia after arteriovenous fistula or graft placement. Classic Steele syndrome occurs when the surgical shunt is too effective, sometimes reversing distal flow and drawing blood away from the hand. It is increasingly recognized that Steele syndrome can also result when there is arteriosclerotic disease, which further compromises distal flow. Existing studies on Steele syndrome have been limited by small case numbers. This study takes advantage of the National Vascular Quality Initiative dataset to determine the incidence and risk factors for Steele syndrome and examine access outcomes after procedures used to treat Steele. The VQI's hemodialysis registry from 2011 to 2019 contained 48,195 procedures. Of these, just over 35,000 with long-term follow-up data were used. 970, or just under 3% of vascular access surgeries, resulted in Steele syndrome requiring intervention. We stratified patient characteristic by the developments of Steele requiring intervention, and we find that patients with Steele were more likely to be white, to be female, to have diabetes and arterial atherosclerotic disease. And they were also more likely to have had upper arm procedures, used prosthetic grafts over fistulas, and had larger target artery and vein diameters at the time of surgery. After adjusting for case mix using multivariable logistic regression, we find that the independent risk factors for Steele are white race, female sex, arterial disease, diabetes, prosthetic grafts, upper arm procedures, and large veins. Antiplatelet use was also a risk factor, and we think that this is because it might be a marker of more severe arterial disease. 6 procedures for reintervention were tracked in the VQI. Most commonly utilized were catheter-based procedures, presumably for treating arterial lesions. 23% were treated with access ligation, and the rest were treated with open surgical revision. Of the 4 best-known revision procedures for Steele, distal revascularization with interval ligation, or drill, was most popular, and this was followed by banding. Revision using distal inflow and proximalization of arterial inflow accounted for just 3% of reinterventions. Excluding access ligations, reintervention for Steele was associated with a slight decrease in 1-year secondary patency rates. However, after we adjusted for case mix using Cox multivariable regression, we find that reintervention for Steele actually was not associated with increased risk of access failure. In addition, we found no statistical difference in patency rates between the various modes of reintervention, although banding did trend towards lower patency rates. In conclusion, severe Steele syndrome requiring intervention complicates just under 3% of vascular access procedures and is more common amongst white females with diabetes, arterial disease, and upper arm grafts. We find that salvage procedures for Steele are associated with good shortened patency rates. Thank you, and I look forward to your questions and comments.
Really nice presentation, Dr. Lee. We wait for the questions. Did you look at mortality with the different procedures for Steele? I mean, there are some reports like drill has higher mortality because patients usually they get the procedure under general anesthesia. I don't know if you were able to look at mortality.
Yes, thank you for that question. We did look at survival after the different procedures with or without steel and between the different procedures for steel. And we did not find a significant difference in mortality.
And I mean, I don't know if you can look at it with VQI in terms of like, if you can define a successful intervention for steel. I don't know if VQI will give you that data.
Yeah, that's a good point. As you may know, the VQI tracks mainly the primary procedure, and then any complications with the primary procedure, including events like steel, are tracked within the long-term follow-up data sets. And so if there are complications of the second procedure, such as the steel revision procedure, it may or may not be completely recorded within this data set. There are some long-term follow-up data sets that record, for instance, after a drill procedure, a ligation procedure following that, and that would sort of give a hint as to whether the drill procedure was successful or not successful. But the numbers for such occurrences were low, and so it's hard for us to estimate whether this is because of the way the data set is capturing or not capturing this data, or if it's because these procedures were very successful. So unfortunately, it's a difficult question to answer.
We have some questions from the audience. The first one, and I think your answer is, was there any information on limb or digit amputation?
For amputation, no, that's not something that is captured in the VQI data set. So unfortunately, we don't have that data.
The next question from Dr. Nelson, how was upper arm AV fistula defined? Can you distinguish between a brachial base versus a proximal radial base AV fistula?
So the VQI tracks procedures based on the target artery and vein and the recipient artery and vein. So this upper arm is defined as anything above the elbow. So anything that originates from the brachial artery and goes to the cephalic or basilic vein above the elbow.
Jason Kim has a question. Were you able to identify if the tapered AV graft, the 4-7 millimeter, provided any protection from developing steel versus a standard non-tapered 6 millimeter graft?
That's a good question. That is captured in the data sets, but I have not looked specifically at that. So that's a good suggestion. I'll look into that.
The one question I had, you mentioned size of the vein, right? What was the size that put you at risk for develop still?
Yeah. So we sort of chose arbitrarily the median vein size as our cutoff for the threshold of looking at whether patients are at increased risk for steel or not. And that number that we came up with was 4 millimeters. So vein size that was greater than 4 millimeters were at increased the risk of steel. And interestingly, it was just the vein size that mattered and not the arterial size, even though before multivariate analysis, patients with steel were also more likely to have larger arteries.
Okay. There's just a comment that the Boston University team look at I think at taper versus non-taper, and there is no difference.
I see. Thank you.
The next question is to follow on Dr. Nelson's point. Do you think we should do more proximal radial artery fistulas versus going to the brachial artery?
I think that makes sense with the sort of, I guess, the general recommendation to go from distal to proximal in terms of also sort of preserving more proximal accesses in case distal ones fail. But I would imagine, based on our data set here, that a proximal radial, I would guess, would have lower rates of steal as well. Just physiologically based on this, you know, a more distal inflow, even though I guess this is sort of not, it's not directly supported by, it's not directly commented on by the VQI data set.
There are no more questions. Again, really nice analysis and excellent presentation. Congratulations. And
Thank you.